Good morning. Thank you for those who are joining. Just to let you know that this is not a formal presentation. It just review our guidelines of how to do a newborn assessment. So I'm going to share my screen, share the guidelines that we have, and I hope that you guys can see it. Okay, so as you can see, it's a guidelines, not a presentation. And the reason we're doing this is for our unit to have the standard performance, structured, organized, and persistence. We do the same by all the physicians. So as you know that the guidelines contain introduction, which tells you that the importance of examining a baby, even a well baby, within 24 hours of life. And the purpose of the examination of one will be first to assess and identify any abnormalities. The congenital abnormalities or malformations can be hidden, we don't see them, and can be obvious, but we can see them. Can be minor, such as you have, let's say, clinodactyly, or you have Mongolian spot, or you have an extranipple. And it can be major, such as you have a VSD, or you have a abnormal brain, or you have abnormal kidney, or you have intestinal obstruction. So we have minor and major. We have hidden and obvious, apparent, and we have life-threatening malformation. Life-threatening malformation is a malformation that if you do not interfere within a short period of time, the life of the baby will be at the age. So you need to make sure when you do your performance to identify these abnormality. The other purpose is to look for birth trauma and look for common problem, mainly cardiac and vascular, cardiac and respiratory, jaundice, and also infection. When we do the assessment, it's vital. So everybody thinking the baby is his mother. So we can do maternal history, family history, and prenatal history and natal history are very important before finishing the exam. If the baby is going home, so well baby going home, no need to do the assessment after 24 hours. But if the baby is staying, we need more than one assessment. So any baby stays more than 48 hours, another exam is important. And another exam should not look at the previous exam, because most of people will do a copy and paste. Okay. The most important to remember in the guidelines that an assessment during resuscitation is not a newborn assessment. A newborn assessment should be in a quiet, in stable baby with the mother, prefer to be with the mother and in front of the mother, so if mothers have a question. So please remember that this is not a resuscitation exam. It's a separate exam. The assessment of a newborn baby, it's vital for our practice, because most of our well baby practice depend on the assessment. Now, any physician or a nurse working in an ICU should have the ability to assess the exam, the baby, and do proper examination. All of the nurses and the physicians should have enough exposure of assessing these babies. Assessing the baby, including the history. The history should be directly from the mother. Anybody who's doing the examination should take the history directly from the mother and not copy and paste it or hand over it from other physician. When we do the documentations, it's vital that before you start to enter your note, use a template. So everybody use the same format. That's one. Second, before you enter your note, you have to discuss it with the nurse. And the same vice versa. When the nurse writes notes, you have to discuss it with the physician. So the note should be consistent between both. And if they have doubt, they have to report to their superior. Any baby should receive consistent. That means the same between physicians and nurses and between the physician themselves. And it should be timely, should not be late, and it should not be more than. So the assessment should include history from the mother, delivery, story around admission, general appearance, physical and vital signs. So we'll talk about some definitions. The guidelines talk about some definitions. So we have admission assessment, which is comprehensive assessment. Before admission, we have concise assessment that is done between shifts between physicians and nurses. So remember, we have a comprehensive admission assessment. We have a concise nursing and physician assessment between nursing shifts and nursing and physician shifts. We have focus assessment. Focus assessment means we're focusing on one particular body when we do a crisis management. So baby has his assessment or her assessment, has his concise assessment, but a problem rises between that. So the assessment should include that particular body that we are concerned about. So this is important to remember this type of assessment. Okay, the assessment should include, our documentation is including gestational age, and there is always a problem with gestational age. The gestational age is calculated from the last menstrual period. That's all, not the ultrasound. It's the last menstrual period. If the date mother cannot know or does not know the last menstrual period or the last one was irregular, then we use ultrasound. And when we say ultrasound, we say gestational age by ultrasound. The gestational age should include weeks and days. Okay, and this is the typical format that we use in writing the gestational age. Now, the days of life is also important, and always there is discrepancy between nurses. Now, in our unit, we consider the first day of life is from midnight. So if the baby born at 8 a.m. in the morning, from 8 to midnight, consider 0. If the baby born at 10 p.m., from 10 p.m. to midnight, consider 0. If the baby born at 1 a.m., from 1 a.m. to the midnight next day, consider 0 date. So our first life days is started from midnight. And the reason is to have a consistent documentation between physicians and nurses. Term baby mean any baby born more than 36 plus. One minute, please. Sorry about that. So term baby, any baby is 37 plus 0. Weight, another problem in an ICU. We should use grams, not kilogram, when documenting the weight. We have the following weight. We have the birth weight, which is the first weight after birth. We have the current weight, which is the weight that we measure after the birth weight. We have also the gaining and loss weight, which is the weight lost from the last weight measurement in the last 24 hours, in the last 12 hours, in the last 48 hours. We have the working weight, the weight that we use for calculation of medications and other measurements. And we use the maximum weight if the baby is not infant or diabetic and macrosomic, or if the baby is not edematous, because in that situation, we should use the dry weight. So the working weight, we use the maximum weight and we approximate it to the maximum 100. So if the baby, and when we change the birth weight, we change it by 100 grams. So if the baby birth weight is, or the current weight is, let's say the current maximum weight or birth weight, let's say 1012, then the working weight is 1.2. If it is 919, then the working weight is 1 kilogram. And when we change the working weight, we change it by 100. So it's very important for the nurses and the physician to use the same weight. We also have other type of weight. We have target weight, where where we want to reach with the weight when the baby is growing. But this is not the purpose. It's the purpose of neonatal care rather than examination. The history should include mother, labor, delivery, prenatal screening, risk factors for sepsis should include. Past pregnancies, any malformation, any stillbirth, genetic, previous admissions, any genetic history from both sides, consanguinity, previous illnesses. Please, Dr. Bushra, please mute yourself. Any maternal condition, and we should include prenatal screening. Now, I'm not going to go into details of prenatal screening. This is most like obstetric care rather than, but we need to list all the routine screening done with the mother. Mostly those affected the baby. These include ABO grouping, RH grouping, rubella status, syphilis status, hepatitis B, hemoglobin of the mother, if there is urinalysis, screening for chlamydia, for Neisseria, for HIV, certain diseases if the mother has thyroid, diabetes, and if the mother is diabetic, then we need to make sure that the last screening was done or not, and if it's done, what's the result, because it impacts the baby. GPS screening for any baby more than 34 weeks, screening for congenital abnormalities, such as screening for Down syndrome, neural tube defect. They have certain markers in antenatal ultrasound, imperforated anus, cardiac, bowel, and so on. So we need to know the importance of fetal ultrasound list. Most important is Doppler, amniotic fluid, expected weight, and malformation. So these are very important to remember when you read the ultrasound. Abnormalities, so we have, for example, a nuchal echogenicity. We have, for example, screening for neural tube defects, screening for imperforated anus, screening for congenital heart disease. We need to know the weight of the baby, expected weight, and we need to know the amniotic fluid volume, and usually expressed as amniotic fluid index, and we need to know the normal that can affect the formulation of the lung. Of course, substance of use or toxicology should be there, HIV status, and so on. Of course, we should concentrate on the need for repeating hepatitis B if the mother is possible. In the delivery, of course, we need to know many, duration of labor, when the membrane rupture, and it's not, the membrane should be listed by date and time. So the date and time of membrane rupture, the date and time of delivery. So we know exactly, not saying it's few days or 2 days or 1 hour. It's better to list the dates. Mode of the delivery, condition of the baby, whether needed resuscitation, and resuscitation means anything other than the 30 seconds of an RP. So if you don't know, the 30 second is drying, warming, position, suction. So if you need stimulation, then that's resuscitation. That's what we call it, active resuscitation. So if we have a resuscitation, then we should be aware of post-resuscitation complications such as hypothermia, hypoglycemia, asphyxia, poor feeding, infection, and so on. All these post-delivery complications, post-resuscitation should be aware of. Importance of gestational age by weeks and days, not saying term and preterm, term, preterm, near term, preterm, severe preterm, all has no meaning. Days, if no days, the weeks should be followed by 0. But if there is weeks, then we should put the number of days out of 7. Preterm is any baby less than 37 plus 0. Late preterm is 34 in our unit, 34 plus 0 to 36 plus 6. And remember that the increased risk of morbidity and mortality in babies preterm, but also there is increased risk of morbidity and mortality for babies delivered before 39 and after 42, and the best time or less complication occur between 39 and 42. We always have to make sure risk of sepsis, and these are maternal temperature, leaking for more than 8 hours, preterm, signs of chorioamnionitis, tenderness, foul-smelling liquor, leukocytosis, group B positive, fetal distress, growth restriction, and remember that mother in pain or in labor is a risk of infection. And once you find out, then you need to go to your guidelines of the neonatal sepsis, and this depending on it. Physical examination should be done in the nursery or in the mother room. Should be warm and quiet, good light. Examination, observing general. So examination should include general appearance assessment, positioning of the baby, universal flexion or not, movement, color, respiratory effort. We should have the measurements of the vital sign and anthropometrics, and then examining local body parts. So you have to have a system of assessment, and the system of assessment, you can go from up, down, from down, up, by system, but you should have a system and you should have consistent with the system. You do the same each time. The examination should be systematic, and you should not assume the baby is normal, even if assessed by previous physicians. So it's a good practice to forget the previous exam and do the exam from 0. But the way you do the exam is not important. The most important is you have a system way of exam. Up, from head down to toes, from toes up to head, from front to back, or from by system. You see CNS, cardiovascular, and so it's whatever you want to do, but you should have system, and you should be consistent and system. Always remember to check the back. Very important. You always have to look at the baby when he's prone and he's supine. So very important to do. If you find any finding, remember it might be transition. So you need to list that and you need to reassess. It's important to look at the baby before you look at the baby. So unaddress and look at the baby before you touch the baby. The general, look at for the gender, look for any apparent birth defect, such as those in the leg or in the hand. Look at the baby nutritional status, overweight, macrosomic, or underweight, growth restricted. Look at the very important to look at the umbilicus and look to the amount of Wharton jelly around the umbilical vessels, because that will give you a good idea about the nutritional status of the body. But also you can look at the thigh and the gluteal area to look whether the baby is a normal weight, overweight, or underweight. Respiratory effort, you need to look if the baby working hard, the pattern of the breathing, any signs of respiratory status. I'm gonna not discuss this because I think everybody knows. Position on the movement of the baby. So baby posture, very important. It's a universal position that reflects. So sometimes you see very quiet, well grab and flex baby, but sometimes you see abnormal position, especially if the baby was in abnormal position inside uterus. So remember, the position of the baby in a prone and supine will reflect the position of the baby in. So you have front breech, you have a breech, you have abnormal position, you might have abnormal head, abnormal face, deviation, all because of the position of the baby. So remember the position, the position of the baby will be adapting the position in utero. But in general, the baby will be in universal flexion. Look at the color, pink, acrocyanosis, central cyanosis, bruises, pallor, anemia, plethoric, all this jaundice need to be. Then you do the measurement, weight and height. The length should be from the top of the head to the bottom of the feet, and when the leg should be extended at the hip and at the knee. Head circumference using fronto-occipital head, chest circumference should be assessed. Of course, all the measurement need to be blotted, so it depends which chart you're using, and we had a presentation about the nutrition and which chart we should use. Whether the baby is mature or premature, but we can use Olsen growth chart, but there are other growth charts that depend on the unit. So we have a growth chart for each, for babies between 33 and 42, and we have another chart for babies less than 32, and then we have other chart for babies who grown after 42. Vital signs need to be recorded more than one time. Maybe every 30 to every 2 hours, every half an hour, or every 60 minutes for first few hours, including the temperature, the most important. And the temperature, that is the most important point here. That's, you should never forget. The first temperature should be checked rectally, because outside temperature of the belly, the surface temperature of the body, reflect the core temperature of the mother. That's why maybe the service temperature will not reflect the actual core temperature. That's one. The second, using rectal probe to measure the rectal temperature, reflect the core, and also assess or help you to identify any abnormal aims. You need to check the respiratory rate, the heart rate, and you need to if you have a sundial, or you look to the rhythm changing of heart rate. Look at the skin, and there are many abnormal skins such as melia. So that's what's called. You need to know what is melia, and there is erythema toxicum, and there is also congenital dermal melanocytosis. So these skin finding need to be mentioned and clear, communicated with the nurses and the mother, because it can have lots of distress and issues if not very clarified to the parent. Nevus simplex also, nevus flammus. The head, very important to measure the head circumference, look at any abnormal hair, all abnormal shape, asymmetry of the shape of the head or the face. Fontanelle, their size need to be appreciated, whether they are full or not full. Sutures, separated, overlap. Skull, if there is any abnormal, such as craniotabes, softening of the skull. Cephal hematoma, caput saxidana, subgaleal hemorrhage. So these, you need to know the terms, what they're meaning, and what's their consequences, and how you manage them if they need management. Any blood loss, damage or injury or cut need to be. Face, very important, symmetry and asymmetry. Crying, and you need to, because it helps you to identify any birth trauma. Sometimes the abnormal movement, if the baby is quiet and not moving, you will miss them. So you need to make sure that you don't miss them, because sometimes they can be missed if the baby is quiet and not crying. You need to be aware of any assisted delivery by forceps or vacuum or difficult in extraction the baby. So you have to be aware of the history. So when you do the examination, you are aware of any birth trauma. So asymmetry, then we move to the eyes. Very important to examine the eye for any abnormalities, and if you can able to do the red reflex. Very important the baby to go. So you need to measure the spacing between the eyes, and for you to know that the space between the eye should be another eye. So hypertelorism can be identified, and you can show, and these are some measurements if you're interested. These are measurements mentioned here. Asymmetry between the eye. Palpebral fissure need to be measured is the part of the sclera that you can see between two lids of the eye. So very important. Epicanthic fold, another fold to identify the trisomy. Widen palpebral fissure or upward or downward movement of the eye, very important. Color of the sclera, conjunctiva, cornea, the pupils, all need to be. Red reflex, it's vital and it's a medico-legal. If you don't assess, later on the baby have cataract. Look at the eyes, external appearance, size, position. So you can always look at the position and determine if the baby have low set ear, which is, it is reflecting abnormality. Look at the junction between internal and external epicanthus of the eye and continue the line. You should touch the upper and lower 2/3 of the ear. So any abnormality of the ear, very important, preauricular tags, because it can reflect internal abnormality. So when you have a tag, you need to make sure that there is no abnormality inside. So you might need to do some assessment. Look at the ear canals, if it's obstructed, nose, shape, nerves, septum, closed, choanal atresia, whether it's a bone or soft tissue, need to be assessed. Mouth, micrognathia, receding chin, any asymmetry of the mouth, presence of cleft lip, palate, soft and hard palate, also natal teeth, any discoloration, such as episthan purals, which is white abnormalities. If you have mucoceles, if you have ranula, the frenulum, ankyloglossia need to be seen. Neck, masses, asymmetry, movement, cystic hygroma, brachial cyst, hematoma, thyroglossal duct, lymphadenopathy, torticollis, and sternocleidomastoid mass, any excess skin. You need to look at the clavicles, they are symmetrical, and then you need to palpate them for any abnormalities, absence of the clavicle, such as in cleido-cranial dysostosis, fracture of the clavicle, so tenderness, or you have an extra joint, pseudoarthrosis, chest, general inspection, abnormal size, abnormal shape, excavatum or carinatum, funnel chest, excavatum, asymmetry, abnormal nipples, chest wall movement, accessory muscle use. Very important, the position. Sorry. Hello? Who's this? Do you have a question? Internipple distance, very important to know approximately what is it. Lung, you need to, of course, in the breast, you have gynecomastia, you have also milk-producing breast, extra breast. These are very important to monitor. Lung, air entry, auscultation, cardiovascular, palpation, chest wall palpation, and for throats and others, auscultation for murmur. Remember that the diseases that easily fool you is the corpulation of aorta that can fool anybody because of the PDA. So femoral pulses, brachial, radial, but the most important is femoral, but auscultation, very important, including the rhythm, the murmur, the heart rate, whether the heart in a correct position, murmurs and the type of the murmur. Look at the abdomen, look at the umbilicus, number of blood vessels, 2 arteries, 1 vein, the size of Wharton jelly, absence of Wharton jelly, oversize of Wharton jelly, abnormal hernia, big organs, any mass, intestinal obstruction, cyst, mass, abnormal liver, abnormal spleen, abnormal kidney, absence of the stomach or omphalocele, gastrostomies are very important, palpitation to feel the organs, very important to look. Umbilical cord, we talked about it. Presence of cyst of the umbilical cord. Genitalia, very important. Say this is male or female. In the male, you have to know the size of the penis. The testes are descendant or descendant. In the male, in the female, you have to look at the vagina. Labia majora should cover the labia minora. So it's very important to monitor that. Also to measure the distance between the anus and the clitoris, or what we call it anal index, whether the anus is anterior or not, because that's always help you not to miss important imperforated anus. You have to look at the vagina, whether it's opening or not, and whether the membrane is bulging or not. In the male, very important to do the testis descendant, and if it's undescendant, where is it? Is it inside or outside the abdomen? Because they know the intervention are different. Whether there is hypospadias or epispadias, and what are the grade. And if you have atypical genitalia, then we have to make sure it's not congenital adrenal hypoplasia. Anus, very important to measure the anal positioning index. And there are many pictures. If you Google it, it will tell you how to measure the anal position index in male and female. Trunk and spine, very important to put your finger and move it from down to up and down to make sure that there is no neural tube defect or any sacrococcygeal abnormalities. Sacral limbo, very important to look and see the end. If you don't see the end, you might use oroscope or ophthalmoscope or any magnifier to look. Extremities, hand and feet, important to count the digits, remember. And when you count them, separate between them to avoid missing the syndactyly. Movement is symmetrical, asymmetrical, moving the fingers or no. Very important to not miss the brachial plexus injury. And you need to know the anatomical distribution of from C1 to T12. Very important to differentiate between ERBS and Klump's palsy. Hips, very important to look for hip stability and do the tests. So whether it's Ortolani or Barlow measurement, but anyhow, you need not to remember, baby should not go home without you assessing or commenting on the hip status, especially for those with at risk of developmental dysplasia of hip, such as having a family history of DDH or breech presentation, or you feel a click during assessment, or there is asymmetry. And I'm done with the newborn assessment. Any question? Sorry, that's very quick review of our guidelines for a newborn assessment. And we will do that once weekly, but next time will be done by one of our physicians. So if you have any question, I will be happy to answer. Questions? No question? No question, I'm going to leave. Okay, thank you for attending. And there will be a record of this quick session on the YouTube. So if you want to if you want to listen to
Thank
the
you, sir.
again, and if you want a copy of the protocol, you're very much welcome. No more questions?
Thank you, Doctor. Thank you.
Thank you, sir. No questions? Thank you very much.